And we're back. We have Marc Surdyka. How's it going, Marc? Good afternoon. It's a bright, sunny day here in Tacoma, Washington. Is it torrential downpour still in California?
No, today has been like 75 degrees. It's been gorgeous. Nice walks outside with Nicole and the dogs. It's been great.
That's that's awesome. Wasn't it flooding or really bad rain the past few weeks?
We did. Yeah, and we
Yeah.
have a bit of a leak in our apartment that's supposedly going to get addressed, but nothing, too major.
Was this the leak that also occurred a year or two ago that you had tried to fix with the windows?
Correct.
Okay. Good luck with that. Leaks are no fun.
Yeah.
Okay, so the topic for today, test, retest, or assess, treat, reassess are the two most common names for that thing. Let's start with Marc. Why do you want to talk about test, retest, or assess, treat, reassess?
Yeah, I think this is something that came up in conversation just between the two of us. But for context, me, Chris, and now Nathan also get together every couple of weeks to discuss patient cases. And as many of the listeners know, I've taught, at the university level for many years. I mentor students, new grads, and residents. And this concept of assess, treat, reassess, I do think is important in our field, and it's emphasized in physical therapy education. But sometimes I think the way that it's presented and the way that it's practiced is quite flawed. And that's what I've seen when I mentor residents. And I think I brought that up to you and asked you about it if you've had any experience with what I was describing and what we'll get into today. But for me, it's kind of this obsession with creating or chasing minor within session changes and symptoms or range of motion using manual therapy and other modalities that's often done at the expense of other likely more important aspects of care. And the purpose is that you're supposed to have this underpinning of clinical reasoning for why you're doing this assess, treat, reassess. And I don't think that's always the case, but we'll obviously get into it pretty extensively in today's conversation.
Maybe for ease of how long it will be, let's just call it test, retest, but we can also use that synonymous term for assess, treat, reassess. We may flip back and forth, but maybe we just start with test, retest. It's a little bit quicker. Do you want to start with, Marc, what typically is this thought of and how is it commonly taught in school?
Yeah, and I think to give a little bit of a historical background is helpful. And there's actually a really nice paper by Neil Tuttle that we could probably link in the show notes that actually gives some of this historical perspective as it relates to more modern science. We're not going back to Francis Bacon in the 1600s. We're thinking about things relative to the medical field. And so he describes this concept as it relates to D.D. Palmer, who's the founder of chiropractic, Andrew Still, the founder of osteopathy, and how they applied it was, you assess, let's say, the subluxation or this theoretical subluxation of a bone, you fix it, you reassess within that session, and that problem is solved right then and there. He gave a nice quote, this same author, Neil Tuttle, from a medical text. And the quote is, "We try the methods until we find the most suitable for that particular case. And during the course of the treatment, we may have to ring the changes on all the methods available." So it's kind of just going through your available options until you find the thing that provides you with the result that you're looking for. The next example was James Syriacs, who's kind of known as the father of orthopedic medicine. And he was one of the first ones where the patient's diagnosis really directed the decision-making. Now, I think the person who's probably one of the most influential is Jeffrey Maitland. And anybody who's a physical therapist or a physical therapy student should be aware of Maitland. You might know him for, the different graded mobilizations, but Maitland was known for much more than that. He really did push the importance of clinical reasoning and these reassessments. So this assess, treat, reassess. From my understanding, he popularized the comparable sign or the asterisk sign, if you've heard of that. And I'm going to take another quote from the paper. The method taught by Maitland involves reassessing pre-selected aspects of the patient's signs, symptoms, or functional limitations, and using changes occurring in these parameters during or after treatment to guide future treatment application. The best known component of the Maitland method is to predetermine one or two asterisk signs to be reassessed immediately after a single application of a treatment technique to gauge the effectiveness of that technique. Ideally, asterisk signs would be active movements or functional activity. So an asterisk sign can be anything. A person could have pain with bending over, and that's their asterisk sign, and that's the thing that you're using to assess, treat, and reassess. So I think a lot of this probably stemmed from Maitland, but I also think it probably stemmed from a lot of the important influences in manual therapy as well, just beyond Maitland. And I'm going to come back to Maitland later, but that's kind of like a nice history of where we're at.
You've touched on it a little bit, but what are the proposed purposes of this test-retest approach?
I think it underpins everything that we do, with the intention is that we're trying to provide objective, patient-centered care based on sound clinical reasoning. You might argue that there's a component of buy-in for the patient, right? If you assess something, you treat them, and you reassess it, and that range of motion improves or their symptoms improve, there's probably some buy-in that may occur. And then there's been an argument that it helps identify which patients have a better prognosis, which is something I have an issue with and something that we'll discuss later on. But I think the main thing is just that, once again, objective, patient-centered care using sound clinical reasoning. It's the opposite of that is assess, don't guess, right? Or don't guess, assess. It's like you want to be as objective as possible. And that's, I think, the intention here.
Do you want to go into when you would or do use this test-retest approach and when it is beneficial? Do you want to dive into some of the research behind it first?
Yeah, let's quickly talk about the research. And there's two things that we're thinking about. We're either thinking about within session changes. So a patient comes to see me, I assess them, I do something, and I reassess immediately after. So that's within session changes versus between sessions. Perhaps I assess something, give the patient an exercise, they come back and reassess that, right? So we're going to be talking about both within session changes, but also between session changes. But I think I have a bigger issue with some of the proposed purpose of within session changes. So there is a systematic review by Rung et al. In 2020 titled "Are Within and or Between Session Improvements in Pain and Function Prognostic of Medium and Long-Term Improvements in Musculoskeletal Problems?" The conclusion directly from the paper is there is no conclusive evidence to support the concept that early changes in pain location or pain intensity offer a good longer-term prognosis on a variety of outcomes, and no evidence relating to early improvements in function. The idea that patients who appear to improve in the first treatment session will do well longer term is not supported by the literature. And a caveat here, because I am going to bring up Chad Cook and discuss some things that he's said and written about in the past, but he's done research in this area. And he has papers in this area that didn't meet the inclusion criteria of this systematic review. And I just want to point that out when we come back to talking about some of his papers and what he's discussed in the past.
So there's that systematic review. What, if any, other research do you want to touch on?
I think that's fine for right now.
Okay.
Yeah.
Sure. When are times that you see this approach being beneficial?
I think it's beneficial in almost everything that we do. You know, the example I might have mentioned to you before we even started this conversation, or maybe I was just talking to Nicole on a walk. You look both so alike, you know. Sometimes I pass my ideas to Nicole, and she's a good person to reflect ideas off of. But like an ACL reconstruction, you're going to give somebody probably some kind of like patient-reported outcome measure. You're going to be testing their range of motion. You're going to be assessing their swelling. You're going to be assessing their strength. And then over time, you're reassessing these things. So let's go back and look at those patient-reported outcome measures. Let's go back and look at the range of motion. Let's go back and look at the swelling. Like, it is integral in everything that we do, going back to the assess, don't guess. And that's more of a between session example. But there's plenty of within session examples that I think are perfectly reasonable. And that systematic review actually talked about a lot of the research that it was looking at was McKenzie, related management, which is, let's say somebody comes to see me and they have low back pain and they say, generally it hurts when I sit for long periods of time, when I bend over to tie my shoe. And during the assessment, I say, hey, go ahead and bend forward. Tell me how that feels. They say, it's painful. I say, try to do that a few times. Tell me if it's better, worse, same. And they go, it gets worse. And then I say, okay, now go ahead and bend back and try that a few times. Tell me if it's better, worse, or the same. And they go, better. And then I go, okay, try to touch your toes again. And they go, oh, yeah, it's better now. Like, that's a simple example of, we assessed that touching their toes made their back feel worse. They did a simple low back extension maneuver, and then they retested reaching for their toes and they felt better. I think that's perfectly reasonable. Once again, I just think it's some of the reasoning behind doing some of these other things attached to this kind of test-retest that I have issues with. And I'm sure we'll get into that in a moment. Is there anything that you want to add to that?
No, I agree with you. Within the session, throughout multiple sessions, throughout multiple months, there's constantly testing and retesting going on through a variety of means, whether it's these patient-reported outcomes, their subjective response, the objective testing, their joint effusion changes, the range of motion, all these things. I totally agree with. I don't really have much else to add to that. Let's dive into primarily what you've discussed, the within session changes, some of the thoughts or explanation as to why people deem this valuable or place so much emphasis on it. What is your concern or hesitancy with specific within session changes or the narratives around those changes?
Let's start with prognosis, because as I said, seeing these rapid improvements within session on, let's say, the first visit has been touted as a way to determine which patients have better prognosis. And I think this idea is an inappropriate justification for manual therapy or other modalities. Like, I don't think manual therapy or other modalities should be used with the intention of figuring out who's going to have a better prognosis. And I'll tell you why. So, nothing against Chad Cook, but he's been vocal about this. So it's easiest for me to pull quotes from him in a written format and in podcast format. And plus, he's just an influential person in physical therapy. So I thought it was reasonable to kind of use some of his examples. So I think it was a few years ago now, Chad wrote a paper titled The Demonization of Manual Therapy. And I'm sure a lot of this had to do with the back and forth he had with Adam Meekins. But this is just one quote in there about, he had like 8 different reasons, right, about why we shouldn't demonize manual therapy. And this was just one section. And so this is a quote directly from Chad Cook. Short-term changes, especially those that carry over beyond immediate effects, have been linked to a good prognosis. Numerous studies have identified that early and continued change to the next treatment session is related to a better prognosis than those who do not exhibit a change from early session to session. this finding involves a positive or negative within session or between session response from a dedicated procedure. The clinician uses the within and between session findings to adjust their treatment dosage, intensity, and application for the optimal targeted result. And I think that last statement in this first paragraph is great, right? The clinician uses the within and between session findings to adjust their treatment dosage, intensity, and application for the optimal targeted result. That makes sense from an exercise perspective. If you prescribe somebody exercises and they go and do them and they come back and their knee is significantly more swollen and their range of motion is limited, we're going to use that information to adjust that dosage, intensity, and application. I'm going to continue with this quote from Chad Cook. And this was like in big italics in the paper. Rapid changes in symptoms at the start of therapy are associated with a good prognosis. Continued, it is important to recognize that these studies included manual therapy as the primary treatment technique, but did not include a control technique to see if the effects were specific to manual therapy. Consequently, it is not appropriate to mention that early change is prognostic, but whether or not the change is specific to manual therapy requires additional study. And so I think that's where I have some of the issue with, is that we've attributed this prognosis to these changes in a patient's symptoms based on manual therapy. But as he said, there's no control technique. So how do we know that it wasn't due to natural history? It's not due to regression to the mean. If it's not due to something else altogether. Similarly, if they were going to get better anyway, why are we intervening in the first place? I know, you know, Chad surely knows that most instances of acute low back pain get better regardless. So I'm going to continue here because I think some of what's been said and written is a bit contradictory. So another quote from Chad Cook that was said in a podcast episode. A lawyer never asks a question that they don't know the answer to already. I think a manual therapist needs to be the same way. You should know exactly what to expect with that patient. There should be no experimentation. And if you're not sure what the outcome is going to be, then they may not be the candidate. One, that's a lot of certainty there. But my question is, based on what he's saying, if we already know how the patient's going to respond, that means we already know the prognosis. Why do we need to incorporate manual therapy or other modalities to modulate the pain? Because it's not the manual therapy or the modalities and the modulation of the pain that are creating a good prognosis. And even by his example here, he already knows that that person probably has a good prognosis, which is why he's using manual therapy on those patients. So are we just leaning into patient expectations? And can we potentially negatively influence these expectations by trying to lean into this, which I'll talk about? And then two other things that go into what he said is that, and I'm not quoting him here directly like I did with the previous ones, but he basically said, if someone has dominant nociplastic pain or more of like a persistent or chronic pain, we likely shouldn't use manual therapy. On the flip side of that, he said, if somebody has dominant nociceptive pain, which would be like a more mechanical pain you can kind of bring on and off, then they're a better candidate for manual therapy. Well, once again, we already know that somebody who has this dominant nociceptive or mechanical type pain is going to have a better prognosis than somebody who walks into your clinic with persistent pain that doesn't have a perfectly reasonable aggravating factor and alleviating factor. So why are we leaning on manual therapy in this example? It seems like we're using it as a crutch more so for poor clinical reasoning and communication. So that's my issue with prognosis. If you have any questions, I'll stop, but I can keep going because I have some more quotes and points here.
Let's keep chugging along.
Okay. So I think another example of this is the lumbar spine manipulation clinical prediction rule. This is the clinical prediction rule if you're not familiar with it. Which is, there's a research study and they try to determine certain factors that would allow us to determine which patients would benefit from a lumbar spine manipulation. So this is a quote from that paper. Patients were most likely to benefit from spinal manipulation if they met 4 of 5 of the following criteria: symptom duration less than 16 days, no symptoms distal to the knee, score less than 19 on a fear avoidance measure, at least one hypomobile lumbar segment, and at least one hip with more than 35 degrees of internal rotation, right? So they looked at all of these things and they found that these things were the things that determined if someone was going to benefit from a lumbar spine manipulation. Now, a point to make about clinical prediction rules is that they have to undergo 3 different stages. They have to require derivation, which is to identify factors with predictive value, which is what this first study did. Then they need to go and do like internal validation and external validation, which is a reproduction of the rule in a different population of patients, which this study, to their credit, they did do. So they did do a follow-up. And then an impact analysis, which shows that there's evidence that the rule changes clinician behavior and improves patient-centered outcomes and or reduced costs. From my understanding, that has not been done for this lumbar spine manipulation. And for most clinical prediction rules, they haven't gone through these 3 different stages. So this is a quote from Haskins and Chad Cook in 2016, where they're writing about clinical prediction rules. So they state, Cook and colleagues found that when different outcomes measures for recovery were used in the creation of a clinical prediction rule, different baseline predictor variables populated the regression model within the same sample of patients. Since no known predictors work for all outcome measures, the clinical prediction rule only applies for one construct of recovery. The clinical implication is that even at its best, a clinical prediction rule only speaks to the specific treatment and outcome for which it was designed and lacks carryover to other patient outcomes. And then I'm going to continue a little bit more. And this was a quote from actually Kai Siegel from Physio Tutors that I liked. And it was referring to this quote or to this paper from Haskins and Cook. So he wrote, a lot of simple derivative modeling methods used in many studies capture prognostic factors rather than prescriptive factors. In other words, the rules identified patients who were going to improve anyway, regardless of the treatment they received. If we take the clinical prediction rule of Flynn, again, just the author of the paper, a duration of symptoms less than 30 days or no symptoms distal to the knee and a low level of fear avoidance are generally positive prognostic factors who favor recovery independent of the treatment. In reality, the natural history associated with those signs and symptoms is very favorable, meaning that the improvement will not be associated with the care received, but with time. So for me, once again, nothing to Chad Cook here, but there just seems to be a little bit of contradictory information of when that information applies as to how manual therapy is important for determining a patient's prognosis based on what he's written. He's kind of said, hey, it can be helpful for prognosis, but in other things that he said and written, it's almost like, well, it probably doesn't matter. It's very specific to specific outcomes, doesn't necessarily have this, transfer. And so to me, I just don't see the value of saying, hey, I put my hands on somebody and they felt better within that session. I know that they're going to have a better prognosis. Your chat with the patient and just like your general understanding of the patient should help you determine whether or not this person's going to have, a certain prognosis. So that's my issue with prognosis. I'm happy to answer any follow-up questions there.
Yeah, I don't know if I have any particular follow-up questions there. And it all makes sense of a lot of those instances, these individuals are going to get better regardless. And it's time better spent not determining the pathway of the specific subgrouping, which we know hasn't been validated. And there's multiple systematic reviews now showing that subgrouping for low back pain just isn't a reliable and valid option. So this time and energy should be spent, like you said, discussing these general prognosis with these individuals, reassuring them, looking at what their valued activities are, not trying to determine your specific intervention. We've had multiple conversations about this in previous episodes of likely the specific intervention doesn't matter a ton because a lot of these specific effects don't work like we think they do. Outside of that, I don't have any specific questions there. How about we go into the other concern for this kind of neurotic looking at within session change? How is that setting certain expectations for these patients? Like, what are potentially the things that may be going through a patient's head if this is the focus of trying to achieve with immediate changes within a session, within the initial eval, or throughout sessions?
Yeah, and this is where my concern actually lies. So just for clarity, I don't really care about the prognostic thing all that much. I just think that there is some flawed reasoning there, and it shouldn't necessarily be used for that manner. But where I think it can be maybe even harmful to the patient is within session. So that's going to be my focus, not the between sessions, but within sessions. Because, yeah, we have to ask, what is it that we are telling the patient if we're doing an assessment and a treatment with the intention of, let's say, modulating pain, reducing pain, fixing pain, and then reassessing it, right? I think, first of all, we might be telling the patient, maybe not explicitly, that the goal of rehab or the goal of coming to physical therapy is for the physical therapist to fix your pain. And the therapist is the one who does it, right? It's this like fixer and needing to be fixed interactions. So that's an issue. I think something that's not talked about is, what about the patients who don't get better? I know that quote from Chad said, like, pretty much with certainty, you should know who to use manual therapy on and who not to use it on, but there's never 100% certainty in anything. So let's say you use manual therapy, a patient gets better, and you go, yeah, this person has a good prognosis. You show them, hey, your pain is malleable. You can get better quickly. What does it tell the patients who don't get better? One, they might think, wow, this therapist is incompetent. I came to this individual, he's doing all these techniques and he can't figure out how to change my pain. Maybe it's also showing that they're kind of, quote unquote, like unique. Like maybe their doctor said, this is the worst knee I've ever seen. And you're kind of reinforcing that belief because now you can't change their pain. And instead of trying to make them this unique case, I think we're better off normalizing pain for people. I've talked to you and Nathan about this, and I've been getting more kind of consults, but I see people who see me who are young and on the verge of getting hip replacements, and they feel heard and they feel seen because it's a more normalized experience for them versus being like, I'm the only person in the world who has this. I can't be helped. Right? So yeah, what about the patients who don't get better? And then we have to ask, do we need to change their pain? Within session, do we always need to change their pain? Are we contributing to this idea that you can be bulletproof and you can be pain-free for life? Are we trying to reduce pain unnecessarily when we should be providing reassurance, as you said, and helping people maybe become more tolerant to pain and accepting of pain? And I understand I'm going to get some pushback and say, well, patient expectations are so important. But I also think that we have, it's sure we do. We have a role for the patient in front of us, but I think we have a societal role as well. And I also think we have to question, when do we push back a little bit or have an honest discussion with the patient? That's what I'm saying is, sometimes I think this is an excuse not to have those really difficult conversations. Like, should medical doctors just prescribe opioids or surgery because a patient wants it? No, you would hope that they're doing it based on their clinical reasoning and the need for those interventions, not just because the patient has asked for it. And I know that our consequences are less dire. But does that mean that we shouldn't have those difficult conversations anyway? And then for me, I think that just one of the biggest things is like, what are the expectations that we are setting? This is something that every resident that I work with, I find it so important that we are trying to set the appropriate expectations. Because here's what I think. A patient comes in, and let's say it's a second visit, and they come in and they go, oh, I had a flare up in my knee pain. And immediately your strategy is, let's fix it. Whether it's, and I'm not bashing manual therapy either. I'm going to discuss exercise here in a second, but it's let's fix it. Let's rub it. Let's put some tape on it. Let's do whatever we can to fix that pain here and now. And instead, if on day one, we set the expectation, your pain is going to fluctuate throughout this process. What we know, and let's say it's patellar tendinopathy, what we know is that this process could take 3 months or longer. And maybe, you have an idea of your prognosis based on how long it's been present. If they come in, they go, hey, I've had this pain for a year. You might say, hey, this might take a year to get better. But it sets the appropriate expectations versus now every time the patient comes in and they have pain, you're chasing ways to reduce that pain. And perhaps you're taking away from the goal of rehab. I'll stop there for a second, and then we could talk about some other examples as well.
Yeah, you're describing what seems a very reactive approach, as there's no weekly or monthly plan within someone's plan of care. It's how are they presenting today, and how do I immediately reactively adjust their pain levels? And that is potentially not looking at the bigger picture of the things that maybe matter the most, of improvement in function, improvement in objective tests, improvement of return to work skills, whatever it is. That's something that I think is very valuable to realize. If you're adjusting your treatment every session, that to make the goal of how do I have them feel better leaving the session than when they came in, it almost comes across as this like spa-esque treatment that we're just trying to achieve these feel-good outcomes. And explaining to the patient early on, there's a lot of trial and error, and I wouldn't be concerned or overly concerned if we have some flare-ups throughout this process. A lot of times these things settle within a few days. These are the things that we would adjust if this lingers. And it's like letting them know that this is common and expected and normal, that these things will occur. And if they do occur, we're not going to freak out. We may or may not change anything. We may try a few more sessions with that intensity, doses, etc., to see if it's continuing to be a trend. It's all these things that you're providing up front, as opposed to not saying any of that. They come in the next session, they have a spike, you kind of freak out or have this chaotic navigation of what's going to make them feel better. It's a very different kind of mindset on the clinician and what the patient is perceiving for their care.
I love that you use the word reactive. When Nicole and I were talking about this yesterday on our walk, she said that as well, that it's a very reactive instead of a proactive approach. And there are going to be components of reactivity. Of course, there are going to be that, but it's just not these huge reactions because you've set the expectations early on. And like you said, the approach kind of comes off as that you're just throwing everything at the wall and seeing what sticks without a real plan in place, which it's actually more work for the therapist this way as well. Just like constantly, like you're constantly falling forward and catching yourself because you're just figuring out, okay, what can I do now to change this pain? What can I do now to change this pain? And there are going to be those days where maybe the pain doesn't change. And that's what I'm going back to. Like, what do you tell the patient then? Or I've seen it where you have like a good session, and then at the end, the last 5 minutes, the patient's like, oh, you know what? After that exercise, my knee hurts a little bit. And then the therapist automatically goes into fix mode and goes, okay, I got 5 minutes. Let's see what I can do to fix this pain. And then, okay, better, worse, same. Patient goes, wow, it's actually a little bit worse. And then the session's over and they have to leave. knowing that their pain is worse, but also with the expectation that that pain is almost like a bad thing and that shouldn't be expected. And so let's go into several examples. I talked about the opioid example, right? Sometimes things can feel good in the short term. It doesn't necessarily mean they're good long term and they're going to lead to a better prognosis, right? So you take an opioid, your pain feels better. Doesn't mean that that's going to be the solution to your long term problem. It doesn't necessarily mean you're going to have a better prognosis. And maybe this is, I'm comparing apples to oranges, but even with something like taping, you throw the tape on and you have to ask, like the therapist has to ask themselves too, not just what am I doing, but why am I doing it? What's the rationale here? An example of, let's say, some long-term reactivity, right? Let's say you're trying to hypertrophy the quads of somebody with an ACL reconstruction. You have a long-term goal in place. I'm going to be doing this weekly dosage at this intensity, with this volume, with this exercise selection. And then one day, maybe the knee is a little bit flared up. In the moment, you're reacting to that and modifying the exercise selection or the intensity or the range of motion. And that's perfectly acceptable. It's not, okay, now we don't do anything. I try to fix your knee pain. One more example. I gave the patellar tendinopathy example. I know I'm jumping all over the place here. So if we need to narrow it down, we can. But this is a little bit more on my mind because I've written about it recently, is the tennis elbow example. We know from the literature that 90% of cases of tennis elbow get better within 1 year without any active treatment. That should be told to the patient up front. Hey, even if you did nothing, most likely within a year, your symptoms are going to get better. It's possible that they get better even sooner. But now, if that's not what we're explaining to them, and it's every time you come in, you're trying to chase this improvement in symptoms, like they have this expectation that tennis elbow is treated quickly and that should get fixed quickly. And that's just not the case. Same thing with like plantar fasciitis, right? There are papers where some people have pain for 10 years, 15 years. And if every time the patient comes in, they're just trying to get a quick fix, that's going to be problematic. And then they go to the next therapist and the next therapist does the same thing. At one point, they get educated saying, hey, the expectation, this is going to take a while and nothing that we do within one session is going to make a significant difference in the long term. And so that's probably one of my biggest gripes, is that this often takes away from the long-term plan. Like you already alluded to it really well, because it is so reactive in nature. And the intention is that it's underpinned by this clinical reasoning. And I think that clinical reasoning is actually thrown out the window a lot of the time. It's just simply, you have pain, I'm going to make it better. And then that shows that I'm doing something that's making your pain better, or your range of motion is improving by 5 degrees, versus, planning out what's the next month look like? What's the next 3 months look like? What's the next 6 months look like? How do I empower you? How do I provide you with some responsibility? How do I create that internal locus of control? How do I do all these things, that are hard? Behavioral change is hard, but just not focusing on this quick fix. And I'm going to come back to Maitland, because like I said, Maitland is well known for his advancement of clinical reasoning. He really pushed clinical reasoning in physical therapy. And are you familiar with Louis Gifford? I think I've mentioned him on the podcast before. So Louis Gifford has some amazing books, amazing writings. He passed away years ago now, but he was just super intelligent. And, he learned from all of these older physios that kind of paved the way for the rest of us and what we learn in university. And I took this quote from Louis Gifford as he was studying under Jeff Maitland in his practice. So he was directly learning from Maitland. And this is the quote from Louis Gifford. It's a long quote. However, manual therapy wasn't all I thought it was. My growing skepticism and desire for rational explanations was quietly growing. I wasn't seeing the results I expected, especially with the large population of chronic whiplash and repetitive strain injury patients who frequented Jeff's practice. Due to the very nature of manual therapy, their problems were effectively reduced to some spinal joint comparable sign. Their range of movement to pain was observed. A very specific mobilization technique was performed, and the range was reassessed. The range to pain invariably improved, and the technique repeated a few times through the session. And then the process was repeated, often 3 times a week in and week out, and month in, month out. I cannot ever recall any exercise of any relevance being given to the patient. The treatment was entirely passive. There was no patient responsibility in the whole process, and the brunt of all therapist-patient interaction was in communicating the symptom behavior during the range of movement assessment. To me, the symptoms were very cleverly, quote unquote, played with, but the patient never moved on. The majority of patients in Jeff's practice had very thick files. So this is just one quote from Louis Gifford. This is also not necessarily thrown, shade at Jeffrey Maitland, but to me that sounds void of clinical reasoning. And I'll stop there if you want to follow up with anything there.
Yeah, what I think something that we can elaborate on top of this is these short-term changes aren't unique and aren't special, and we don't have to just harp on manual therapy. It could be the same thing with exercise or any of these other effects. Like, things can occur acutely for a variety of reasons because of this change in sensory experience. And you're almost, it's common to be like, do you feel better after that? It's like just trying to enforce that after you do something, you're trying to get this immediate positive result. And it doesn't have to be because of the manual therapy. It could be an exercise, it could be cupping, it could be whatever it is. And yeah, maybe we zoom out and not have it be forced on manual therapy, but that is that one example. But it's common in so many areas of any intervention.
Yeah, and like I said, I think this is actually useful for students and new grads, knowing that we don't necessarily have a whole lot of control over a person's pain, especially in the moment. Now, this is not an excuse to shut down, not be super vigilant with your assessment and your treatment plan, but it just gives you permission to say that sometimes the patient's pain is going to fluctuate. Maybe it was something that you did, maybe it was something they did, but oftentimes it just happens. And knowing that and letting the patient know that just puts a little bit less stress on you. Not every patient outcome is tied to exactly what you do, fortunately and unfortunately. If we could, we would love to make everybody 100% pain-free and return to everything they can do, but we don't always have that capacity to do that.
We've touched, we've kind of circled it, but what are your suggestions and better approaches to look at a patient's plan of care instead of this reactive approach? Can you kind of summarize what are our better options?
Yeah, and these are conversations that I've had with students and new grads and residents over the years, is that zooming out to the big picture is important. If they're setting goals or they have an idea of how long a certain diagnosis might last, let's say the tennis elbow example, 90% of people get better in 1 year. If you have that in mind, that changes everything. It allows you to say, I don't need to see this patient 3 times per week for the first 4 weeks. It doesn't make any sense. Instead, you could say, hey, this is what we know. These are the expectations. You're going to have fluctuations in pain. Those fluctuations in pain could be activity related. They could be related to how much you're gripping something, how much you're playing an instrument, how much weight you're lifting, what kind of exercises you're doing. We're going to try to find ways to modify all of that and make rehab sustainable and manageable and help you meet your goals. But it's not about running at every side of pain or trying to fix every sign of pain. And I think that's such a people listening might think that it's a fine line. You gave the example, or you brought up exercise as well. So let's say somebody has this patellar tendinopathy and they have pain with a certain exercise. First of all, we would say, hey, pain is normal. As long as it's tolerable, this might be okay for you to continue with this exercise. Is that fine with you? And they might be fine with that. So in that case, we're not doing anything for the pain. There might be cases where now a certain exercise is intolerable and we're finding ways to modify it. We're not necessarily finding ways to modify it because we're trying to find a quick fix for pain. We're trying to modify it because perhaps we're trying to still create some of those adaptations we're seeking, without taking a complete break from whatever exercise. And then even with like isometrics, I don't know if I necessarily prescribe isometrics as a way for a patient to say, hey, try this out and see if it immediately reduces your pain. I just say it might be another option for exercise that's more tolerable. So yeah, your question, like, what should we focus on? I think it's just focus on the big picture. What's your plan of care? What's your clinical reasoning for that plan of care? What is the patient's prognosis and how does that influence your plan of care? And then make sure that you're reassuring the patient and you're setting appropriate expectations so that you don't need to react to every spike in pain that they experience within sessions or between sessions. And I'm not saying that you can never do manual therapy or tape. We hear this like it provides a window of opportunity or it modulates pain. Sure, in some cases, if that's something that you want to do because you feel like it allows you to help that patient load their knee better, that's fine. I think you just have to be very careful when you have someone do a squat and you go, okay, let me try this. And you tape their knee and it goes, it still hurts. And you go, okay, let me try this. And you mobilize their patella and they go, it still hurts. And you go, okay, let me try this. And you do a soft tissue mobilization or massage to their quads. You go, that still hurts. And you go, okay, let me do some cross friction to your right. And then you're just digging deeper and deeper into this bucket without stopping to think like, why am I doing this? Does the patient need it? Does the patient even want it? I think we assume that the patient always just wants this quick fix. And I don't know if that's always the case. I think sometimes we project our beliefs onto the patients. Obviously, yes, patients do come to rehab because, they don't want to be in pain. But there's a lot more to it than that as well. What do you think?
Yeah, I would say one of the biggest things that I'm really glad I did as a student was I created, and I can link this in the show notes, is I created a pretty large Google Doc on, I'm going to look up a condition, I'm going to see what the evidence or what the literature is on the natural history of this. If nothing was done, just time itself, how long on average does it take for people's symptoms to resolve? Or if something was done, an intervention, what was the general prognosis or timeline? And having those bucketed things for a variety of conditions, whether it was acute low back pain, chronic low back pain, frozen shoulder, an ankle sprain, all these hamstring strain. It's like just having general timelines in your head as a student or a new grad, that you've already touched on it, Mark, but that provides so much context to you as the clinician and to the patient. And another thing is, if you're getting near discharge and you're discussing to a patient, like I had this example last week, I had a patient come in, they've had persistent low back pain. They had an episode, it was pretty severe. They came to me towards kind of the end of their flare or their kind of acute on chronic episode. And on our last session, I discussed, okay, one of the things we do know is that there's a high chance of this reoccurring. And one of the biggest predictors of pain or injury is prior episodes. So if this does happen again, let's say in a few months or a year, these are the things that I would set you up for to think about. And these were the things we discussed throughout this plan of care. And you're also not within just this plan, but also letting them know, hey, if this does happen again, it's not uncommon months, years down the road. These are the things you can kind of think about or consider. I'd reassure you that this is common. Remind yourself you had this improvement over a few weeks or months. That's largely going to happen again. I'd be more than happy to discuss this if that does occur, but you're also just like in the future, I just want to let you know. So it's like you're setting the expectation for this plan of care, but towards the end, you're also saying, this is how we're going to approach this if this does happen again. And I think that's important to touch on as well here.
I love that mindset. I think it's so important to provide that empowerment, provide that resilience, not just within your current plan of care, but all future plans of care. Or, whether that patient comes and sees you for their elbow, or maybe they didn't see you for their elbow because of the strategies that they learned from you. Hey, Chris said that if my pain flares up again, not to freak out, especially since it wasn't traumatic, nothing else is out of the ordinary. I should just probably try modifying my activities for a little bit and do some of these other things. And if it doesn't improve, great, I'll go back and see Chris. Oh, my ankle hurts a little bit. Same idea, right? We're trying to create, like I said, I think people joke about it, right? Like you tell a patient, like, I want you to be your own physical therapist. And that's not going to happen, but you can provide them with some of the strategies that will be useful for them in, during future episodes of pain, whether it's related to the same exact pain or to other episodes of pain. And I think, what ties in with this is just that uncertainty. It's very hard to admit that uncertainty. And sometimes a patient might not come back because you admit that certain. That's certainly a possibility. But I do think it's our duty to put that information on the line. And I like the case examples. I saw somebody remotely for a consultation yesterday. He's been advised by 2 surgeons that he needs a hip replacement. He just wanted to see, hey, is there any possibility that I could avoid this? And he's never had formalized rehab, so my suggestion was, well, based on what we know, you could probably try 3 to 6 months of non-operative management. That option for surgery is always there. This is the rationale for why people normally get surgery. It's not just based on imaging. It's based on symptoms and function. And there's different routes for when people say, okay, it's time for surgery. And then I say, I cannot guarantee that non-operative management over the next 3 to 6 months is going to prevent you from getting a hip replacement. Like I don't have any percentage for him, right? These are the general strategies. These are the things you can focus on. You're going to have flare-ups. Things are going to go up and down. Some movements are going to be more problematic than the other. But overall, you're trending toward, the goal is to trend upward toward the things that you want to do, knowing that you're going to have some pain and limitations along the way. And if you aren't able to accomplish your goals, well, then that surgery is available to you. And, he was very happy with that kind of explanation because it was just straightforward and honest. And, I didn't look for ways to go like, oh, let's try to do a quick band mobilization to see if we can quickly improve your pain. Like if he's already had 2 surgeons say that, hey, you probably need a hip replacement, me trying to find a quick fix of his pain in the moment is really not going to make any long-term difference.
Any other things you wanted to touch on or general final thoughts on this topic, Mark?
No, I think we covered a lot of it. I realized that I brought this topic up to you a few weeks ago or a few months ago. And then just in preparation for this, reading some of these papers and diving into the history, maybe passionate is a word, like how passionate I am that we should not overemphasize the importance of the within session changes, or maybe the flip side of that is not overemphasize pain or the importance of quick, transient changes in pain to the patient, because oftentimes I think that might send the wrong message, potentially implicitly, even if we don't explicitly say something. What about you? Any last things to?
Well, to that point, another example, I had a consultation with an individual last weekend who's had persistent pain, and his primary goal was to resolve all of his pain. And I was brutally honest during the initial consult, and I said, pain is very messy and it's a moving target, and it's something that's going to be very hard for us to have immediate control over. These are some of the things that I think maybe I can help you out with more confidently, of these objective changes within multiple weeks and months, these functional tasks that we could get you back to. My hope is that you're not having this huge flare of symptoms throughout that process, but that we're just kind of increasing your ability to live your life while still having some of these symptoms. I think that's a little bit more something I feel comfortable with setting as an expectation versus trying to completely resolve all your symptoms. And that can be like very vulnerable as a clinician to say that because you don't know how the patient's going to respond, but at least you're being honest to yourself and to the patient. So they, seem to take that well. And at least, let's say a month from now or 2 months from now, they have the same level of symptoms, but their just capacity for a variety of things and increased. That's a more realistic goal. And I think that's what I would emphasize to a lot of clinicians is maybe just harping to patients like pain is super messy. We have a ton of things we can use for acute symptom management, but long term, let's look at these bigger factors and these big things you want to get back to. So that's another example and maybe something we can, or at least I can end with there.
Yeah. And I just want to say, I don't want anyone to leave this podcast thinking Marc said assessments are useless. I cannot overemphasize how important I think good listening, objective examination skills, like the basics are for physical therapy students and new grads. I think sometimes those things kind of get overlooked, right? That the whole pendulum swings. Like, I think that stuff is so important, and I think evolving your plan of care based on emerging data within sessions and between sessions is great. Also, keep doing that. Just keep asking yourself why you do what you do. And I think, that'll kind of help your clinical reasoning and critical thinking over time.
All right, let's call it there. We'll link all what you cited and some other resources so people can dive into it and think through their own perspectives, and no one has to agree with us on all these things, and there can be back and forth discussions. So it's more of a thought process and for people to examine their own line of reasoning and care for patients. All right, we'll call it there. Thanks, Marc.
Thank you, Chris.